Thanks so much for having me. Can you hear me okay?
Yes, it's great.
Okay, I'm just going to share my screen. Are you able to see my slides all right?
Yep, looks good.
Okay, thanks so much for the invitation to speak today. Today I'm going to just speak about the screening risk for depression and probable post-traumatic stress disorder among Canadian paramedics. And before I begin, I also wanted to do a land acknowledgement. I'm here from Toronto, Ontario, so I wanted to acknowledge that I'm on the traditional territory of many nations, including the Mississaugas of the Credit, the Anishinaabe, the Chippewa, the Haudenosaunee, and the Wendat peoples. For today's seminar, I'm going to provide a bit of background information on the occupational cohort, which is Canadian paramedics. And then I'm going to talk about the data set from which I draw from, which is the CORSIP project. And then I'll talk about methods, some preliminary results, and discussion that all focuses around two mental health disorders, which are depression and post-traumatic stress disorder in the context of the COVID-19 pandemic. So to give you a bit of context on what paramedics do, I worked as a paramedic for 10 years in the Toronto area, and it's a very difficult job. Paramedics are exposed to a lot of traumatic calls that they go to that is thought to predispose them to risk for certain different stress-related or mental health-related disorders. And so what they do is they provide emergency medical care, and they typically transport patients via ambulance during potentially life-threatening situations. So when we think about the exposure of concern, it's trauma. And so in the psych literature, we often refer to this as traumatic events, traumatic incidents, or critical incidents. And for this presentation, I'm just going to speak generally to it as in terms of trauma. Paramedics also respond to and work in uncontrolled and unpredictable environments. Unlike a hospital or clinical setting that's well lit and temperature controlled and fairly safe, this is not the case for paramedics. They may respond to violent situations in someone's home. They may be responding to an upside down vehicle after a collision in the ditch on the side of a busy highway. And so that unpredictability really can play into the stress that these workers are faced with. On top of that, we can think about this exposure to trauma as fairly random. Paramedics are often assigned randomly to the calls that come in if they're closest to them. And so we really can't predict whether or not we're going to be going to a call that is traumatic or not. There's more calls arguably in urban parts of Canada, but there are also more paramedics staffed in those areas. But it's not all bad. It's a fun job. You get to work with a partner. You typically work in pairs. For most frontline paramedics, you work 12-hour rotating day-night shift rotations, where you might work stretches of 2, 3, 5, or 6 in a row, and then have the same amount off to kind of work about half of the days in the month. And you spend most of your shift in ambulances, stations, hospitals, and the scenes that you're called to respond to. There are about 40,000 active duty paramedics across Canada, but there is a lot of heterogeneity of practices across jurisdictions. And this is problematic when we're trying to study the mental health of these workers. Paramedic practices are fairly different across the world. In developing nations, there may not be paramedics at all. And so, for example, here in BC, you have one ambulance service, which promotes a lot of standardization. Here in Ontario, we have 55 different services, 55 different policies and procedures, PPE, ambulance ventilation design, everything can be very different. And again, that really poses a lot of problems when trying to narrow down what are the common threads that may be compounding mental health injuries among this cohort. And lastly, paramedicine is rapidly changing. Much of what they do has just been borrowed. It's been borrowed from military origins. It's borrowed from emergency medicine, from nursing, from firefighting. And so slowly we're starting to see more research that's validating the practices that they follow. Slowly they're validating the emergency medicine practices that were intended for hospitals in the field. There's also more evidence and a growing focus on mental health. We're seeing evidence coming from paramedic-based research, and we're also seeing more presumptive legislation that's intended to support and recognize that paramedics are at risk for mental health disorders. Historically, it was musculoskeletal injuries that would be what ended most paramedics' careers, and we're seeing this shift. If you look at this photo, we can see hydraulic stretchers, ergonomics, lifting techniques, and policies really have done a lot to safeguard paramedics and prevent these injuries from happening. And in that, we see the emergences of more and more mental health diseases and mental health injuries being observed among this cohort. Okay, I know there's a lot of information, but we've level set, and I just wanted to start with a polling question. And I'll read it out. What proportion of Canadian paramedics do you believe would reach retirement age? Okay, and I would say that you guys are close. It's actually 4%. So about 4% of paramedics, based on some numbers from about 2 or 3 years ago, from some associations and from some unions, state that the retirement age is about 4%. And although paramedics have to work a bit longer than firefighters and police officers, they usually have a normal retirement age. This retirement rate is one of the lowest of all occupations in Canada, and it's quite concerning. And it's apparent because we do see quite a lot of paramedics are leaving the occupation, and the burnout rate or the longevity of a paramedic's career is typically between 2 and 5 years, especially in more urban parts of Canada. Next, I just want to talk about where I got my data set. And I know we're here to learn about the depression and the PTSD risks, but again, I'm just trying to provide enough context to the audience. The CORSIP project is where I got my data. It stands for the COVID-19 Occupational Risks, Seroprevalence and Immunity among Paramedics, hence the acronym, the CORSIP project. And this is a joint project from a wonderful team at UBC and a team that I'm part of at U of T that was funded by the Public Health Agency of Canada, intending to target certain occupations that were at risk for COVID-19 to really better understand how it was being transmitted early in the pandemic. And so this ran from January 2021 to January 2023, and we were able to recruit 4,100 participants from Alberta, British Columbia, Manitoba, Ontario, and Saskatchewan. It's not all of Canada, but it's a pretty representative sample. About 80% of Canadians live in these provinces, and typically where people live are where paramedics are employed around that population density. The way our participants provided us with the data was they could go online, provide their health card number and their paramedic badge number, and then they were invited to complete a questionnaire, and they could print off some serology or lab tests, and they could take that to a Dynacare or a Life Labs to get some antibody testing. And they were encouraged to do that every 6 months. If they were in more rural or remote areas, they could ask for mail-in dry blood spot testing, where they could provide their own blood spots on a piece of paper, and they could send that to our lab. From that, we were able to get their N-level antibodies or natural level antibodies from the nucleocapsid of the virus, or their S-level or spike protein antibodies, which would be indicative of their vaccine-mediated immunity. And we would actually provide those back to the participants to promote some engagement with follow-up questionnaires and follow-up blood work. So from this, we really have this robust data set with personal and occupational characteristics. We've got SARS-CoV-2 immunity measures, which is a fairly good proxy for both exposure and a vaccine-based immunity, and then some mental health screening instruments, which I'm going to talk about next. So the two things I want to talk about is in terms of diagnostic screening instruments. They're not diagnosis per se by a physician, but they're more screening tools that have been validated psychological measures that are used to screen at more of a population level. And these validated measures have pretty high agreement with if a person would meet the criteria for a disorder, that if they went to follow up with a family or a mental health specialist, that they would be a lot of agreement with that. So the one we used for depression was the Patient Health Questionnaire 9. And this is 9 questions where they rate their symptoms of a depression in the past 2 weeks from not at all to nearly every day. We picked this because it's a tool that was validated with paramedics workers in other studies. We can sum those items together to give a depression severity category, or we can choose a cutoff or 10 or more for meeting the criteria for major depressive disorder, sometimes referred to as clinical depression. And this is an important cutoff because this is when paramedics would be encouraged to reach out to a mental health professional and consider treatment options. Their duties and their personal lives may be impacted. The other measure also validated among paramedics was the primary care PTSD 5, and this is for probable PTSD. They were asked a question of, had they experienced trauma in their life? If they said yes, they could proceed on to answer 5 yes/no questions regarding PTSD symptomology in the past month. And for this, we just use this cutoff score of 3 or greater. In terms of my methods, I used R programming, did some descriptive statistics to understand the population, and then some bivariate analysis of those same demographics based on depression and PTSD severity scores. So ordered those scores and then looked for differences, for example, in the severity scores by gender, by age, or by job title. And I used non-parametric methods that I've listed here because everything was not normally distributed. And then I did multiple logistic regression to look for MDD and major depressive disorder and probable PTSD based on those cutoff values that are indicated on the right here. And I really did that just to look for important predictors for these disorders. I did stepwise selection using bidirectional elimination based on AIC. And I created separate models for male and female workers just because the differences in prevalence rates were so apparent. And I'll talk a little bit more about that later on. So I know this is a huge screen, so a lot of information, but these are all the characteristics I thought might be important that I included in my analyses. And I'll just run through a couple of quick things to understand the population. Firstly, about 3,200 paramedics. That's because I really focused on frontline paramedics. So I removed some nurses and some non-frontline deputy chiefs and chiefs that really wouldn't interact with patients and be exposed to the trauma. Most were male, but we do see a lot more female paramedics entering the occupation, which is wonderful. And it's especially helpful in terms of looking for gender differences. Median age is about 36. Most are college trained, as that's an entry to practice requirement for paramedics in most of Canada. Most were white. Most were basic or primary care trained, which would be your first level, your 1 to 2 year college program. Most came from BC and Ontario. Most were employed on a full-time basis, and they worked 12-hour rotating shift patterns in urban parts of Canada. So what did I find? So in terms of prevalence rates, we see that about a third of our population met the criteria for major depressive disorder or clinical depression, and about 40% met the criteria for probable PTSD. We asked the participants, and these rates come from our initial intake questionnaire when we had the largest sample size. We do see that the sample sizes at the top here have dropped a little bit from that 3,200, and that's because we had to only include participants that answered all of the questions. So all 9 depression questions and all 5 PTSD questions, as to not underestimate their severity scores. In terms of PTSD, we asked them to report their scores during COVID-19 and then before COVID-19. And so before COVID-19 would be prone to a bit of recall bias, but the pandemic had already begun, but we really wanted to see if there was a difference statistically before and after, and there wasn't, as reported by the participants. In terms of looking at the bivariate analysis based on, if we look at the table, depression severity and probable PTSD severity, We saw that female paramedics had statistically higher scores for both, as did full-time versus part-time paramedics. Age and work experience, we saw kind of an inverse relationship. The older and the more experienced paramedics had statistically lower severity scores for depression, and for probable PTSD severity, education level, primarily master's or graduate level education, had statistically lower severity scores, so it was quite protective. When looking at both of these scores together, we did see a strong positive correlation between depression and PTSD severity. And I use Kendall's Tau, and it's quite a low p-value, and the reference values are right here. This isn't surprising because when I look in the literature, when we think about trauma-based exposure, about half of the people that develop PTSD actually concomitantly suffer from major depressive disorder as well. Okay, I will launch the next poll question. What proportion of CORSIP paramedics indicated suicidal ideation in the preceding 2 weeks on their intake questionnaire? I think we're still in that first question.
Just trying to switch to the next question.
No worries.
Just waiting till we get a little closer to 70.
Okay, perfect. So the majority of you are right. It was 9%. And so concerning statistic, and where I got this from was the last of the depression 9 questions actually asks about suicidal ideation. So took this metric by itself to get an idea if they had had any suicidal ideation at all. And 9% of our cohort had said that they had thought about committing suicide. And we really don't have a surveillance system to look at this, which is quite concerning. And we really don't even have much data on suicide rates or suicidal ideation. There was a foundation that had put this at about, put the rate of suicide at about 56 per 100,000 Canadians back in 2016, I believe it was. And this is probably still underestimated. Using that same data set, that was about 9 times that of firefighters, 3 times that of 3 times that of firefighters, and about 2 times that of police and military personnel. But again, there's a lot of reasons why family members and friends may cover up if a paramedic commits suicide. And if we go back and be proactive, we really don't have a lot on suicidal ideation in terms of surveillance. In terms of longitudinal trends, so like I mentioned, participants were encouraged to complete multiple questionnaires 6 months apart. So on these graphs, if we look at the top graph, I've just indicated the proportion of paramedics that met the screening criteria for major depressive disorder in blue and for probable PTSD in yellow, just to see if there were any longitudinal changes. And we can see that for MDD, the risk kind of stays about the same. If anything, it kind of goes down by questionnaire number. Whereas probable PTSD, we see this rising, peaking around questionnaire 3, and then falling off. Because the enrollment was on a rolling basis, I thought it would be important to look at things based on time. So the bottom graph looks at the same thing by calendar quarter to adjust for this. And we kind of still see the same thing. MDD risk stays about the same, and then it drops down around Q2 2022. and then probable PTSD goes up, peaks, and then drops down. And so about Q2 2022, this may be when a lot of paramedics perceived that it was the end of the pandemic, and the stress related to it kind of started to decrease or to wane. And if we look on the far right of the graph, those prevalence rates may be closer to what they are during non-outbreak conditions. Okay, the last results I'm going to talk about were from my multiple logistic regression modeling. And so I created some force plots. And like I said, there were stark differences between females and males. So I created separate force plots and separate models based on these genders. There was a third gender category where there were several different identities that participants could choose from, but there was no statistical differences in this group, and the sample size was quite small. So if we look at these force plots for major depressive disorder, and we look on the left for females, the dots in blue were factors that were statistically significant, and those in red were not significant, but retained in my models based on a priori criteria. And so, for example, with females, being employed on a full-time versus a part-time basis was associated with an increased adjusted odds ratio of about 1.75 for meeting the screening criteria for major depressive disorder. If we look to the right for males, we see that age was slightly protective, but being an advanced care paramedic for job title versus primary care, working 24-hour shifts versus 12-hour shifts, and working on a full-time versus a part-time basis, all increase the adjusted odds ratios of meeting screening criteria for male participants. If we looked at probable PTSD, again on the left, we see that age is protective of females. On the right, same thing for males. And if we look at race, we actually see that this category I dichotomized between not white and white, and so those that were not white actually had about 0.55 the adjusted odds ratio compared to the white reference group, or if we flip that, about 1.8 times adjusted odds ratio for white versus non-white in terms of meeting the screening criteria for probable PTSD. And then in terms of full-time versus part-time, about 2 times the adjusted odds. The last models I looked at were for meeting the criteria for both MDD and probable PTSD. And so the only one for females was other shift schedule. So this would probably be some sort of, and this would be compared to 12-hour shifts. So some sort of other 8-hour modified Monday to Friday schedule. Whereas males, age was protective, Indigenous status quite high, adjusted odds, full-time versus part-time, advanced care versus primary, 24 hours versus 12 hours were all significant predictors. I know that was a lot, so I kind of put things in this table just to pick out a few things that I noticed. Firstly, for the predictors on the left-hand side, these were all significant. But it looks like for females, it's very unifactorial. One thing seems to be most important, whereas males, it's quite multifactorial. Working as a paramedic has given me a little bit of context, and I've also looked at the literature, so I might speculate on why I think these predictors are significant. For age, I just think it's confounding because paramedics that leave the occupation for mental health reasons are never going to get to higher ages. For race, I speculate there's something about non-white in terms of being protective against probable PTSD and their ability to be more resilient against trauma. Indigenous may be the opposite, that they have that background predisposition to be at greater risk for both of these disorders. Advanced care, they are the most highest level care that would respond to 911 calls. So I speculate it could be that added responsibility in terms of medical authority. And then full-time, if you're working 4, 5, 6 days in a row, 12-hour shifts in a row, that really has an opportunity to compound that exposure, right? If we think about exposure like that sawtooth pattern with chemicals or any type of exposure, it really does build up that cumulative exposure that may compound upon itself. In contrast to part-time paramedics that may have 2 shifts and then 2 or 3 shifts off and then another 2 shifts, that really may allow them to have that time to catch their breath and build their resilience. And then lastly, shift schedule. So a modified or 8-hour schedule for females for both is protective, and then for males, not allowing 12-hour, 24-hour shifts seem to concentrate that risk, and so maybe that's not a great idea for paramedic workers, at least. Okay, so to summarize, the CORSIP paramedics or Canadian paramedics had a high prevalence rates for major depressive disorder and probable PTSD during the COVID-19 pandemic, and that the COVID-19 pandemic may have impacted their mental health risk. Nonetheless, we have very little data on baseline risk during non-outbreak conditions, particularly for Canadian paramedics. And I really wanted to pontificate on the fact that female paramedics had a disproportionate risk for both disorders, and that's why I created separate models. On the right here, I just threw a small table that shows the prevalence rates of these disorders by those genders, and we can see here that the proportions are much higher for females, and statistically they are much higher when I did a test of proportions. And the factors that are associated with MDD and PTSD screening risk did differ by gender, so there may need to be different approaches to protecting female and male workers. Nonetheless, age, full-time employment, and shift schedule were common predictors regardless of gender. There's been a somewhat recent systematic review that looks at ambulance personnel, and it did focus on PTSD, depression, and anxiety. And they had a really unique point that they made in the article, is that we really do have a lack of data regarding the impact of workplace traumatic exposure. And I paraphrase it here, but it precludes our ability to differentiate from non-occupational symptomology. In the population, there is risk of depression and PTSD that may not be related to their work. But even more importantly, there's individual factors that really need to be considered if a paramedic is to succumb to a psychological or stress-related injury. And so, for example, if I'm a paramedic working with a partner and I go to a call for a patient that has stage 4 cancer, and my loved one is also experiencing similar things in my personal life, that may be a traumatic exposure for me, but it may not be for my partner. So when we think about that, measuring the exposure without relying on maybe workplace injury or near miss forms, which there's often a lot of stigma around actually completing that, or there could be a lag period before the traumatic symptoms develop, really makes studying this exposure so much more difficult in terms of creating that link between exposure and then disease or illness. Last poll, and then one more slide. So I'm going to read it out. Since the passing of presumptive legislation in 2016, PTSD-related lost time claims for Toronto paramedics services has increased by how much? Okay, great. You guys are on the ball. Maybe you're Googling it. I don't know, but it was 56%. And interestingly, in the report I found, they said that there's a lot of increased stress-related injury claims that were associated with exposures to infectious diseases during the COVID-19 pandemic. And so to really put that into context, since this legislation passed, it's not a linear increase. We actually see this rapid exponential increase in these PTSD-related lost time claims for Toronto paramedic services. And the reason that I wanted to mention this before my last slide is because I think that paramedic services and employers really are trying to do their best to support paramedic mental health and well-being. And so to bring this full circle, what are the policy implications for these employers? I think that the paramedic services across Canada are facing extenuating human health resource pressures. They can't staff ambulances, and that's posing concerns for public safety. And so based on my research, based on other similar research, which there's not a lot of, what are the considerations that could be for age? Historically, we didn't want to hire older paramedics because musculoskeletal injuries were more likely, but now maybe actually hiring older paramedics may be beneficial for mental health reasons. Approaching gender specific approaches for females versus male paramedics may be something to consider. In terms of race, hiring a more diverse workforce may be more resilient to succumbing to trauma-related injuries. Level of care, ensuring that that burden of responsibility is shared between the advanced care and the primary care paramedics. In terms of employment status, if you're going to lose a full-time paramedic to lost time and long-term disability, maybe there's an opportunity to be proactive and to put them into a part-time role, temporarily, so that they have those shifts off between the long stretches to build back that resilience and to possibly return to a full-time status later. And then lastly, shift schedule. So working 24-hour shifts may not be great as it concentrates that exposure, and then working 8-hour modified if you have caregiver responsibilities, if you're female, may be actually quite protective. So I am seeing more and more tools like this. I found it from Health Quality BC's website. It's from the Institute for Healthcare Improvement. It's one of their featured tools. And it's nice to see more and more of these enablers and these handouts that really geared towards first responders and really safeguarding their psychological PPE. And so as we start this discussion, I'm sure you have some questions, but I wanted to pose a question that I ask myself pretty much every day is like, what could psychological PPE look like for paramedics and other first responders? Like, what are the rose tinted glasses? What are the tools we can give them? When it's often that we take a very we don't take a proactive approach. We bought all the PPE in the world to protect paramedics from COVID-19, but for psychological injuries, we often wait until they're injured before we refer them to help. So I thought I would finish with that. And I just wanted to thank the team here from UBC for inviting me to speak, and for all of you for the time to listen. And I really hope you'll ask some questions. So thank you very much.